I think is the worst moment for me during all the Congress with the preparatives. It must been is great, but now I think it's the worst moment because maybe all of you were waiting for this moment during many weeks, and I have to introduce our keynote speaker, but I can do it. It's impossible to introduce Dr. Juan Gervás, so what can I say? It's impossible. So it's incredible to be in Juan here today. I know it's a very big effort for him to be here. He's very busy always, and it's incredible for being here. Juan, thank you very much, really. So we are going to continue. Okay, it's our keynote speaker. So really pay attention because you are going to enjoy it a lot.
The first important question, there anyone from the United Kingdom, including Scotland? Someone from Ireland? No? Well, I ask you pardon because my English, I'm destroying your language. So, but I hope the rest of the audience can understand me. This is the only reason why I use PowerPoint. I belong to a political party against PowerPoint. A very little still political party, but growing. We have seen Prezi, is the competition. I prefer Prezi, and I prefer nothing. But understanding that my English is so bad, you need to understand something of what I say, and I use PowerPoint. This is the first question. The second question is in connection with the whole meeting. I'm speaking about values. But I'm speaking very relaxing. I'm speaking of very hard question, close to crying, but also laughing. So relax, enjoy. This is not an academic, thank goodness, place. This is a normal place. So we are normal people, we can speak each other, we understand. And the third question, I'm general practitioner, but now pensioner. We decide to retire before, now 65. At 61, we leave the practice in the mountains, in rural doctors, in very rural, isolated place, very close to Madrid. To devote the rest of the time to teaching, writing, thinking, traveling, the things you cannot do when you are a rural general practitioner and you have patients who die on Sunday, because people die also on Sunday. And the general practitioner, we must be there on Sunday, if possible. It's extremely important that the general practitioner sign the form, certificate, drink a coffee, and recognize that the family has done perfect work with the person has died. This is a role, a duty of the general practitioner. So we have said that we cannot be in all places at the same time. We have been practicing from around 40 years. And the only difference with our colleagues is that we write. We write every day. I speak in we, not because I am the next Pope. I'm trying to, no, it's because here is my wife, Mercedes. Yeah. Well, it's not only my wife, it's also my planner, and we are both physicians, and we sign almost together because we discuss the papers, the concept, and so on. And we have published from the beginning what we are doing, and we are publishing in Spanish mainly, but also in English. And some people can discuss with us about our writings. And this is the reason perhaps why I am here, because we write. And still we write. And we write very heretic statement. The last one, we had a strong battle with epidemiologists and public health officers, is about breast cancer screening. Noticing people that all of us has cancer. Wow! Even you? Yes. And the last beautiful paper was published in Nature. Did you know the scientific journal, one of the best of the world with science, published a paper, and the title is "All of Us Had Cancer." So when people hear this, they feel shocking. They invite me to comment about values around prevention. And there are two questions in prevention. Can you see the giant? This is Goya picture in the Prado Museum. The giant is more than fear. It introduced panic. But is panic now? The injection of panic is very, very common. You can see the last World Health panic with the pandemic, the flu pandemic, the swine pandemic, was only panic. In order people got the injection, the vaccine, and take Tamiflu. And this was done on purpose. We have now in Spain, in these days, another panic with the meningitis B vaccine. Is in Spain, the government decided only use in hospital, not in primary care, not in the calendar. So the pediatrician inject panic in the families, so the families go driving to Andorra, to Portugal, to buy the vaccine. This is panic. They are introducing fear. They are introducing not only fear, this unpleasant emotion. They are going further to control persons. So this is more than, for the patient is fear, is the feeling of doing nothing about prevention. For the doctor is confirmed. You are concerned, you feel guilty, you have the feeling, it's also a bad feeling. You have the idea you are not doing enough. Your work is not well. You have something wrong. The question of avoidable, something you can prevent, and this is too much. You cannot avoid that your patient die. I don't know. People say breast cancer screening saved 700,000 of lives. It's not true. Just only change the cause of death. We doctors do not save any lives. All people will finally die. We change the cause of death. By the way, in this case, in the case of the breast cancer, we change only the cause of death, and we do not decrease the total mortality. So the few women, 1 per 1,000, who do not die of breast cancer, died of another cancer. Yeah. You decrease from 5 to 4 the total number of cancers. In 1,000 females, 50 to 69, every 2 years mammography during 10 years. But you do not decrease the total number of cancer. With mammography, 21. Without mammography, 21. So my patient in the rural area say, so mammography produces cancer. Yes, cancer not in the breast, but some kind of cancer. The question is that in many cases there are errors, and including, for example, radiotherapy. Radiotherapy destroys your coronary artery, so you have more probability of having myocardial infarct. And you have biochemistry, you have chemotherapy, and you have, of course, surgery. So the question is, now we are dealing with a new concept, incredible, a perversion. worse than sexual perversion. That means you are thinking now that disease is because we make something wrong. That means if the patient has Parkinson, it's because we are making prevention. And if you have myasthenia gravis, you are not making prevention. If you had flu, it's because you are not making enough prevention. If you had diabetes, it's because you have no. If you had hypertension, if you had a lung cancer, if you had anything, now disease is becoming something associated with errors in clinical prevention. This is totally new and wrong. Because we think that one was prevention. No, this is sometimes. From time to time, it happens that prevention is better than cure. But only from time to time, and very rarely. It's very unusual that prevention works. The last example was in the New England Journal of Medicine. In the New England Journal of Medicine was published, I think, last week or 2 weeks ago, a beautiful paper about surveillance of people after a single colon adenoma. It happened that people in the program die with more frequency than people out of the program. And it's much better to do nothing. And we are speaking something very normal in our consultation. You had and they order you to come back every year for what? For your business, for making money, for having a waiting queue, for having a work, or increasing the size of the service or for what? Or for my health, because it's not for my health. First, Dunahan. We cannot introduce activities which produce more harm than benefits. And this is very, very common. Perhaps there is someone of outside the European Union. There are people from outside the European Union. Hand your hand. But you are BRIC. You are from Brazil, you are from Russia. Oh, important countries now. Oh, be careful. You belong to the BRIC. In the European Union, we are 500 million inhabitants. 500 million inhabitants. Per day, there are 75 people who die because of traffic accident. 75. In the European Union, every day, because adverse effects of medicine, die 600. Do you imagine that the Ebola came from Africa to Europe and every day kill 600 Europeans? Do you imagine the terrorists making 600 per day? Do you imagine Ryanair, every day 600? You will travel Ryanair? Do you will trust Ryanair? Do you trust your doctor? It's exactly the same. People trust the doctor after that. So, first, do no harm. Prevention is not a function of primary care. This is shocking. Not so much in the European Union, but a lot in Brazil, or in Uruguay, or in Colombia, or in whenever WHO has strong power. WHO, you know WHO, the World Organization of Health, is very toxic. Try to be far away. because they translate this that think that primary care is prevention. Primary care is not a function of prevention is not a function of primary care. Primary care function are accessibility, are coordination, are not offering prevention. Prevention is just one of the thousand of activity and not the more important. This is the title of a paper we published in The Lancet. Is clinical prevention better than cure? This was the title. And the abstract is sometimes, not always, and in many cases, no. Clinical prevention is becoming a problem. In my opinion, and more opinion, the paper was signed by Barbara Starfeld and Jonas Heath also. Clinical prevention is now a real problem for clinical care in primary care. You need to think twice to be a preventive counselor. You know now this kind of counselor that counsel you about fitness or about how to buy beautiful things. Don't imitate it. You are not a preventive counselor. Patients has their own values. One of my patients cried every time received the letter by the mail inviting her to go to the mammography screening. Just to receive the letter, she cried. Because remember his mother's death. This is very unusual, but you must know. This is your patient. You need to know. And we do not know our patients. We do not know the values of our patients. The best paper was published in Norway. They demonstrate asking the doctor, do you know your patient? And the doctor says yes. And later on, they ask questions about the patient. And the doctor knows nothing about the patient. Does he like the cinema? Does he like dancing? Does he like life? Does he like going to the religion fusion? Does he like? I don't know. I don't know. What do you know about the patient? All. Nothing. You just encounter the patient, but you are ignorant about your patient. And this is the case. And prevention deals with very, very deep values. So think twice before being a counselor. And of course, also because we have very scientific errors. All people emphasize how important is early diagnosis. Huh? No. A good doctor, from time to time, care about early detection. Early detection is not always an ideal. The last paper was published for people from Germany. There is someone German here? Because this is nice to the German doctors. German doctor has no strong quality in general. But in this case, it's a joke. But in this case, I might recognize that the paper was excellent. Do you know DSM-5? The new mental disease classification, where they recommend you to early diagnosis of cognitive impairment. Before becoming Alzheimer, you can make early diagnosis. The discussion was in the British Medical Journal. But the numbers are for Germany. A group of doctors make early diagnosis of cognitive impairment in elderly and follow the patient. According to the early diagnosis, they will be in the near future patient with Alzheimer. But they follow the patient. And they discovered that half of the patient came back to the normal way of thinking. And 25% of the patient are stable. And only 20% go worse. Do you think what means for me to receive the early diagnosis from my general practitioner that in 3-4 years I will be Alzheimer and recognize it, not him, not my brother, not my wife? And this is not true? What will happen there? Because this is the question. Early diagnosis in many cases is wrong. It's exactly the problem with cancer in breast. Many early diagnoses are wrong. You have cancer, but there is an error of prognosis. This cancer will never develop. Never. So they tell you, you have breast cancer, and it's true, early diagnosis. But it's an error, because it's an error of prognosis. This cancer has no problem at all. The classical study was done in 84 in Finland with autopsy. You know autopsy? Autopsy with a medical autopsy, not sexual autopsy, the perversion. Medical autopsy with people who has died with no thyroid disease, and making autopsy of, they make 2 millimeter cut, and they discover cancer in around 40%. And they calculate that it make thinner, slice, 100% of the population has cancer. This was replicated in many countries, including Spain, exactly the same. And this was replicated with prostate cancer. Prostate cancer was common in people with 30 years. 30. Who has here 30 years? Me. Oh, very little. Oh, 30 is close to you. Ooh. They make autopsy with people who has died in traffic accidents. And they make careful autopsy study of prostate. And cancer was present as 30. So we live with cancer. Cancer is part of us. Early diagnosis is not always an ideal. What happened? So a decision to attend screening may be as intelligent and correct and normal as to not participate, because behind our values. If I do not participate in breast cancer screening, I am abnormal, I am incorrect, I am awful, I am silly. If I do not vaccinate myself against flu, I am incorrect, I am silly, I am not wise, and this is not true. It's the value behind the decision, we need to respect it, and could be very different. The question is that clinical prevention becomes mandatory. It's incredible, even with children. You must be here next week to wait and measure the child. And you say, why? Because the protocol. And because the protocol, they organize your life. You are 30. Oh, I need to take your blood pressure. Why? Because you are 30. And what is the problem? Because the protocol. So it's a kind of mandatory organization of the whole patient life and general practitioner life. This is joking, of course. But finally, you have no time to go to visit the dying patient at home. because you are thinking, making this kind of prevention, this kind of mandatory prevention. They are organizing your life, and they decide that making prevention is more important than helping people or dying with dignity. And this is not the election of people. Probably people prefer to have a good death than to have the blood pressure measure. This could be, excuse that, in Brazil is very curious because there are people, technicians, who help you. So they are in another room. And every time the patient comes to visit you, the technician take blood pressure, measure the patient, and wait it. The next week, the next day, 100,000 of times. So why do you do it? Because the protocol. So they have finally, again, I insist, we ignore our patient life, the way they live, the way they feel about the illness, the way they enjoy life, the way they suffer the illness. Of course, there are many people fond of vaccination. They like the vaccine, the flu vaccine. And myself, I inject very carefully the flu vaccine. And I said, well, it's because you like it. Do you like it? It's because do you like it? And I prescribe ibuprofen for a child with fever because you cannot support the child with fever. Do you understand the point? Because fever should not be prevented or treated with ibuprofen, paracetamol, or physical measures, except in very special cases. But this is common in the hospital. If you carry the children to the hospital with fever, they decrease the fever in any way. I think if the parents are not there, they put the children in the refrigerator and close the door. 1, 2, 3 minutes. Open up. So we are continually taking decision without knowing the experience of the. This is the title of another paper. The concept of prevention, a good idea gone astray, and the summary is yes. Prevention, when in the year 1960 start with risk factor, was destroyed. Prevention now means nothing. Prevention is something we make business, money. Prevention is production of money and losing our time. And our time is the best thing we can give to our patients. So we cannot lose our time with prevention without limits. Do you know Physicians Without Frontiers? No, yes. Medicine Sans Frontières. Médicos Sin Frontera. We need to have limit. We need to see physicians with borders. We cannot work without borders. And the borders are the limit where harms are higher than benefits. We cannot cross this border. We need to be physicians with borders, with scientific borders. And our borders are the limit where the intervention makes more harm than benefits. So we need to start a movement. It's just gradually, but more than this. We need just to have borders. We need to have limits. And we need to have air conditioning, please. It's not because my jacket is. Thank you. This was not in the. Oh. So, why is prevention important in primary care? Because we are the only who know a little the patient. You are the only one who can understand the female consent about the breast. You are the only one who can understand the young male concerned about the cholesterol, are the only one who can understand a little the patient. And for that reason, prevention is important in primary care. But first, we need to know the patient. And second, the patient needs to know us and to trust us. This morning, Bernardino is here. Ah, there. Ooh, far away. I am not so dangerous. Bernardino emphasized the need of continuity. But what is happening in the European Union with continuity? What is happening in the UK health centers with the principals, you know, the principals, the general practitioner of my age, with more money, the principals organize the health center, and they contract young physicians and pay almost nothing, and they work with the machine, making money. That's me controlling the key, and nurse. And they say, no, it's not important, the personal relationship. The whole population for the whole doctors. And of course, we need here people who make more money. So if the government pay nutrition, if the government pay food care, and I had a team, and I am the orchestra director, you know, and I count the money. And this is not a joke. You can read, I think 3-4 weeks ago, an editorial in Lancet of an important group in Europe about the future of primary care in Europe, and you cannot believe it. It's against primary health care. It's against general practitioner. It's against continuity. The important is the team. And we have informatic technology who can help us in the coordination. And personal relationship is something old-fashioned. It's incredible. It's against science. It's against what is modern. And it was published in the Lancet. We are preparing a letter to discuss this editorial, because it's incredible. What is happening is this. This is also from Goya. Prevention is eating our patients and us. This is Saturno eating his son. So we have developed a monster, clinical prevention, who takes no care of the values of doctor, of patient, and is eating us. We have no time for patients. We lose patients. We lose clinical care in between prevention. What are my conclusions? It's part of human dignity to assess risks. Our patients are right when affected to smoke. They decide to smoke and to live a little less. And this is perfect. This is perfect for him. Of course, you have explained why, etc. It's perfect not to have a vaccine. And you need to explain the field of vaccine. We can discuss later on, if you like, why the problem we have. And the second and last conclusion, with or without prevention, we have made an error. We have selected big physicians. And physicians are living with suffering, illness, pain, and death. And this is our field. You can do whatever you like. This is what Goya has selected in family medicine. Thank you. Wait a moment. I will explain. We had a lot of meetings, our group, a lot. Usually like this, without smoke. There is not a smoke, no? industrial smoke, without pharmaceutical smoke, without Coca-Cola smoke. It's incredible to be here, some people speaking about the smoke, and later on in the dining room, Coca-Cola, which is very dangerous for health. So we had a lot of meeting, and we always do not laugh. Because people in the audience know, usually more than people here. So, but how aplaudir? Slap? Clap. To clap has a political use. I had been 1 week ago. I'm a very risky person, you can understand, no? I make sex without condom. With my wife only. But without condom, I understand my patients. I'm a very risky person. So, epidemiologists and public health officers invited me last week to discuss about overdiagnosis in breast cancer screening. And I went there. And the ambient was very, very, very cold. Incredible. And when the opposite epidemiologists spoke about overdiagnosis of breast cancer, the audience clapped, like in a political meeting. And when I spoke, the audience said, top, top. Oh my goodness. And later on was terrible, terrible, including insult. Insult, se dice en inglés? Insult. With this reason, I wrote 2 pieces of paper about prevention and cancer screening. One very popular about the ribbon, ¿cómo se llama? El lacito azul, ribbon. Oh yeah, the blue. No, it's not blue. No, the ribbon is not blue. It's pink ribbon. Less pink ribbon and more information. And this was not mine. This was in the British Medical Journal by the director of the another German, by the director of the Max Planck Health Center for Risk, the best in the world, I recognize. And a little against Germany because the austerity and so on. But I recognize that Martin is not part of the Angela group. So I'm ready for question, and if you ask not me question, I will ask you question. So, see? Because Scotland. Are you from Wales, England, or England?
I think that you're right about the fact that GPs have lost the relationship with their patients. It's a big problem in the UK. But in the UK, now if you become a GP, your salary is based on the prescriptions you give, the injections, the flu jabs that you give, the number of people you stop smoking, and you have certain targets. And if you don't meet the targets for stopping people smoking or giving people the flu jab, then your practice will fire you. So how do you propose that if I chose to do that?
What is your name?
I'm still a medical student.
Medical student?
Yeah.
Oh, you know thing. Oh.
Yeah.
Almost no sex until now. Perhaps you know D'Imagine. D'Imagine was working for many years in Chris Ward School of Medicine in New Zealand, and now he's working in McMaster in Canada. She wrote a piece of paper, terrible, about this question. You know, many years ago, not many years ago, around 10 years ago, the British government decided to change the way of payment to general practitioners. And they put a list of targets. Do you understand? You measure the cholesterol, you vaccination, you etc. And the target was so difficult that people expect that no one in UK will obtain the full money, because it was extremely difficult. The general practitioners are more eager than the government. And in 1 year, around 97% fulfill the full target. So they have the full amount of money. And the question, imagine on me, this is an ethical problem. If you can manage a general practitioner, the British general practitioner, so easily, I have totally lost my trust in British general practitioner, because it's just only a question of money. Well, no. You must be a general practitioner. With this idea, you must be a general practitioner, but with ethical background. Mercedes and me, we had never signed, Mercedes, my wife, we had never, she is a physician also, we had never signed the contract with the authority. Never. And this is extremely difficult in Spain, because it's less money for you, even if you go over the target. But you have not signed the contract. And for the team, even for the nurse, and it's not easy to negotiate with nurse when there is a little amount of money. But we organized to say, no, I don't sign this. When they offer the target, we take the target, and we go to the British Medical Journal, to the New England, to the JAMA, to the Annal of Internal Medicine, to the Primary Care, Scandinavian Primary Care, and we wrote a paper. This target is again this target. So please don't ask me to follow your target, because I will go to a jury if you oblige me. This is not very common, but should be very common in the future, I hope. There is a strong movement against this prevention without limit. We need prevention with limit. And it's an ethical question. I ask your pardon because I joke about any country, even about Spain. But it's only a joke. When speaking seriously, I recognize the value of any country and any health professionals. More questions? No question. Do you agree with me? It's impossible. This is because you have not understood my English. Yeah.
Okay. Well, I'm Silvia. Okay. And well, I just wanted to say, I think at the present time, none of us want to become a GP because of the money, because I don't think none of us is going to become rich working as a GP in the future, considering the circumstances. So I truly believe that, I mean, most of us, we just choose to become a GP because we really like, I mean, working with people, no? And sometimes it's true that at the moment it's hard. It's hard because you have an idea when you start studying medicine. You have an idea, you have a concept when you choose specialize in general practitioner, and after you realize step by step that circumstances are not the one you're supposed to, and that's I mean, I don't know how to explain that in English, but that's a big beating. I mean, on your heart maybe, or on your soul. I don't know. It's hard to accept that. But because we have been talking about feeling, we have been talking about sensations, emotions. I think we are all different. We have all different values. Okay, so I think when you become a GP and you are working with people, there is not just a way to work with that people. Maybe you want to, I mean, work with protocol because you need that to organize your mind to treat your patients in the better way you know. And maybe not, maybe you are more like an anarchic person and you can, I don't know, guide your consults in another way. So I think at the end, what you have to do, what is important, you have present in your day and in your treat with people is that whatever you do that thinking that person you have in front of you is trusting you. I don't think when we speak about we are in an equal situation with patients, I think that's not true. That's a lie. That's a big lie. We are not in the same situation because I'm not asking for help. I'm not telling anything of my life to my patient because I don't want to. I don't think it's necessary, in my opinion. But they are trusting me. They are trusting me. Very I don't know, difficult emotion they are having in their lives. They are trusting me in the fears they have, considering the disease they have at the moment, or the symptom, or the sign. So I think, I mean, it's just the way in which we deal with that, how we accept that, and how we give back to patient these emotions and this situation. I don't know if it's good to have protocols or not, but sometimes they are useful too. And
a lot of perversion. 4 years, President. First question about emotions. Mercedes and me, 2 more general practitioners, we record every time a patient cries. Do you know cry? To cry? To cry is the hardest emotion in the consultation. When the climax go to one patient crying, is what we call a sacred consultation. You need to stop the time and to develop around the patient a crystal ball. She feels comfortable and true. Who teach this? We produce the paper in Spain, in Spanish. No one journal in Spanish like to publish it. We send the paper to the European Journal of General Practice. They reject. It's finally published in the Brazilian Journal of Family Medicine into English. You can read it. It's very easy. You just go to Google, crying patient, Gervás, and you find it. It's so frequent in practice. In no one book of family medicine is a word about a crying patient. What to do with the crying patient? To cry with the patient? To touch the patient? What part? Because this morning they advise the back, here. You must take care. Perhaps the elbow. Sit down with him or with her. Give a handicap or handicap. What to do? How to deal with this emotion? No one word. It's more frequent than cancer of thyroid cancer, but no one word. We are purely biologists, family medicine, general practice. This is one question about emotion. The second question about guidelines. Most guidelines has no scientific value. You cannot follow because you are killing your patient. Have you read the paper, the most cited consulted and linked paper in PLOS Medicine about nothing of the publication of today are right? It was done by Stanford, John Dennis, looking at the New England, JAMA, British, the 10 last year, and the best study. And these studies are totally wrong. So be aware with the guidelines. Most guidelines are wrong. For example, the kind of guideline I love, simple guidelines. Tetanus vaccine, 5, 6 shots in children and teenagers, and no one until 65 or no one. This is a guideline that most people do not follow. Now in Ukraine, there is someone from Ukraine. They are short of vaccines. And one of the samples is, we are very short of tetanus vaccine because we need for people who is here in the world. Why? If you had a good vaccine in the whole population, they can support a war without problem with tetanus. But it was put in the newspaper, and the WHO is considering. So we can follow some very simple guideline with scientific base. The estimation is around 65–70% of the guidelines has no scientific value. That means make more harm than benefit. So the question, when you select to be general practitioner, family medicine, you are fooled. Totally. Yeah, you try to know everything of all, and this is impossible. So you must recognize that you have a lot of limitations. You need to, and you deal with person. And every person is a very strange person. We are very abnormal. Believe me, I am very, very abnormal. And I suspect Alberto is very, very abnormal also with this. And she look normal. Oh, this is terrible. It's worse. It's look like a female, normal female. So you deal with person with that totally abnormal. Anyone. There is no norm. And in science there is almost. The question is, try to become a healer. We are not scientific. You can read New England, you can read British, you can read anything. I read Nature, Science, I read extreme things. You can follow me in Twitter. And you came back to the first one. Well, this is an example of my English. So if you are here, you have I share with people my knowledge. So almost every day I comment the whole bibliography, the whole papers and articles, and comment I put into English and into Spanish if I can. This is, I receive no money for it. It's for free, and nobody needs to pay me. So yes, we have our election was totally wrong. We select to be physician, we select to be general practitioner, family physician, we select to be in the clinical practice. And this is almost impossible to be done. At the same time, it's very beautiful. It's very beautiful because you end everyday consultation with a lot of things to go to the bibliography, to the library, because you know nothing. I have been studying, I study today, every day, hours, when working in the clinic at 4 in the morning, 4 a.m. And at the end, I think I comment with Mercedes, with my wife, that the patient probably meet during the weekend to prepare a special clinical situation the doctor do not know, and they are not in the book. And they make a term, so the Monday one, the Tuesday. So at the end of the week, I have every day some special situation of patient is not in the book, not in any journal. They make on purpose, I'm sure. More questions? We have time. We have time. You know, the resident, can you hand how many are resident here? Oh, thank you. The resident of family medicine, the resident of general practice, only need to learn 2 things. How to deal with time and how to deal with uncertainty. Just all. This implies to read almost every day New England, etc. But it's only 2 questions. So I hate when people say, we had no time, or we had no interest, or we are ignorant.
My name is Mauricio. I'm from Brazil. And I'd like to thank you, Juan, for having mentioned the blood measure tension in Brazil, because we are obliged to do that. And that's the point of conflict. If I don't measure the blood tension of my patients, my team will not receive an additional at the end of the month. And that's one example of the many protocols that we have to follow. And well, that puts me in a situation that if I want to know that person, go deeper into that, and I don't want to measure that blood pressure because it's a protocol following, so we have to check many things instead of coming to know the person. So I thank you, because that gives me a lot of strength to follow what is not the, let's say, what the council says us to do. So I feel as a resident in a kind of jail. Our coordinations, our teachers, our paper says, come to know the person, like you are saying now. And that's what I like to do. And then the council says, measure the blood pressure, check the hemoglobin glycosylada, and then the state interfere in the private life. Then we come into a conflict. I have to say to that person to stop smoking, but they don't ask me to ask the person why is she or he is smoking and what he gets from that, if that's a pleasure or not, what's going underneath that, what's the, I don't know the word in English, the sujeito, the subject, what's inside that. That's the council doesn't want to know. And then we come into a problem of control. I think we are being used by the council to control people, and that's a political thing.
Thank you. Mauricio is from Brazil, and Brazil has almost 200 million inhabitants. But it happened that I know him personally, in between 200 millions. Mauricio. There are two answers to your question. One is the ethical one. To say you personally, I do not measure blood pressure every time the patient is with me, because it's idiot. One. Second, join the team and make an ethical team. This team compromise not to make more harm than benefits. Because this, we do not measure blood pressure every time. First, establish agreement with the patient. The government asks me to measure your blood pressure every time. It's totally idiot. Do you allow me to lie the president of the government and to put artificial and to record in false? Do you understand in false? Invent your blood record every time you were with me. And last, with the community. In Brazil, there are community council where they are always discussing things has no saying. I have been in community council. Why not to discuss this question? This community agree with the team not to record idiot things that the government oblige us. Do you allow us to record in force without we invent? And you establish with the community a strong connection, explaining that this is idiot. I had no TV. I'm very abnormal. I had no TV. But one of our good friends gifted this American hire is about policy in Baltimore. The why. Do you know the why? The why? In the why, one of the police in Baltimore decide a free drug consumption cartel. And in fact, he established a few streets where drug addicts can friendly enjoy drugs. Of course, he loses his position. But because I'm very curious, I went to internet to read free urban area consumption drugs, and there are a few. Even in Lisbon, there are a few streets where drug addicts can buy and enjoy, yes, and enjoy and Hanover. Well, I will not tell you the total number and place. It's not Palma de Mallorca. Just in case. So we need imagination. We have a strong power. We are physicians. If you are an honest physician, if you are not ignorant, if you have ethics, and if you work with your heart and with your brain, you are extremely powerful. The community will believe you, follow you in a way you cannot believe. We have been, Mercedes and me, paid by the Brazilian government, traveling around Brazil, traveling around 20,000 kilometers, 20, like around the earth. So we were in many places, mainly in places where there are a lot of drug addicts and so on. And you can notice when the health team is a good health team. Good health team, good health professional can walk very safely, having drug addicts and gangs and without problem. Why? Because they are a treasure for the community. You can kill anyone except the physician. You can kill anyone except the nurse. Well, and we notice where the physician and the nurse and the rest of the team are no compromise. And in opinion, they went in helicopter. You know helicopter? They go in helicopter to the health center, down, and come back home in helicopter. Of course, because they are not rich, they went not in helicopter. They went into car, and they open the door of the car, and they, like in a jail. So we can establish compromise agreement with the community to share our concern, to be frank. And from time to time, we can go to the media, to the journalists. They have a strong interest from time to time. We cannot be corrupted. This is corruption. You are accepting to do something which is not right because the money. This is corruption. And you are a public employee. It's so more worse than a private one. And we cannot be ignorant. We cannot believe that guidelines are right. Usually, no. Most of them are not. And speaking about values, sorry for being so deep. More question? Well, Martin, because but I speak the Harding Center of the Max Planck.
Hello, Martin. Thank you, Juan, for the great speech. Maybe we can profit all of your experience, and I think it's lots of residents, like you were telling us, you don't know why you're a physician, why you're a GP, or it's maybe lots of questions. So maybe you can give us the vision or your vision after your experience, how you would imagine how we can change it, how we can change the system, how we can change the way of making family medicine in Europe. So maybe some ideas.
Martin, you are insulting me because I insist that I write. So I had a paper about this. Yeah, well, this was a very, very interesting paper. Never published. The most interesting paper are never published. Well, I will cry probably because this paper was written by 3 persons. One is Antonio Duran. Antonio Duran is living, now is working mainly in India. Is now someone from India? No? Is working in India. WSO, the World Health Organization in India. But he has been working for many, many years in Copenhagen, in the European Union, WSO. Antonio Duran is also professor in the School of Public Health of Granada, Spain. And the second person is Barbara Starfield. And the third, me. And I was in between, because Barbara Starfield was more social, more psychological, more Antonio Duran, more biological, more. And when discussing the paper and having almost the final version, Barbara Starfield died. So we cannot publish the paper. But it's in the Equipo Cesca. If you write in Equipo Cesca, Barbara Starfield, Gervás, and it's about the future. How we imagine the future. We recognize that the world has changed. It's not the same that in the beginning of the 20th century. It's a different world. But one critical question is personal relationships are becoming more important. You had your personal shopper helper. You had money. And you had your personal fitness advisor. And you had a personal doctor. If you had a good general practitioner, you had a personal doctor. And you can explain to the very elderly patient, lady, I am your personal doctor. Have you seen how this actress has a personal advisor of shoppers? But aren't you personal doctor? Like, it's exactly the same, but in health. So personal are becoming more important. Service at home. Even the prostitute go at home, just in case you know. Yes, you can buy pizza, you can buy Amazon book, you can buy anything, sexual intercourse, and come home. You can just wait. Except the doctor. General practitioners are decreasing home visit. This is a big error. And it's in connection with the other one. We need to go to very complex situations. A good general practitioner has timely and right diagnosis. First. Second, has right use of the public or private resource. And third, can organize the care of very complex patients. We need to focus in complex patients, not in simple things like hemoglobina glycosylada. This is very simple. Or to weight patient, or the table of cardiovascular risks. This is not for general practitioners. This is very simple. We need to deal with very complicated patients, with a schizophrenic patient who has diabetes and homeless. This is your patient. The elderly female who has Parkinson, has isolation, social isolation, has no money, is living alone, and has no leaf, and has hip arthrosis. This is our patient. And we need to decrease the number of face-to-face encounters in the office and increase the number of face-to-face encounters at home. Many of the face-to-face encounters can be done by electronic way. And if you are in Germany or in Australia, I still can be your personal doctor. You can, by Skype, WhatsApp, contact me. But we need time for very, very complicated patients. This is the synthesis of what we need to offer. And the last one, this was a discussion. We need, I have joked about the director of orchestra. My opinion, and that's a related discussion, we need to be pilot of aircraft. You know what is a pilot of aircraft? You need each of one, the nurse, the administrative, the technician, also an aircraft. So you offer almost everything to the patient sitting here. In the moment, you cannot order this female to come back for the pap smear next week. You cannot order this female to come back to order everything just in the moment and make it. And there now we have technology. You can offer incredible things to your patient with near testing, near treatment. With your patient sitting with you, and you can carry this to home. There are technologies you can carry, and you can solve almost every problem. You can be a pilot of an aircraft, a very complicated aircraft, and you can afford to take care of very complicated patients. We are confounding with this kind of simple prevention, mechanical. We are losing our role, and we will be in the near future. Do you know that in Philadelphia, United States, there are a lot of machines to measure not only blood pressure, but they have also Hamilton scale, and you answer the Hamilton scale, and they diagnose you depression, and they recommend you the doctor is close to, because we are losing the opportunity of being personal general practitioner, personal physician in the way we are going. In the editorial in the Lancet, they recommend also to have pediatricians and geriatricians in the health center. Do you understand what I say? They recommend to have pediatricians and gerontologists. So college from the East, I have been also in the East, when the East was the East. Not now, because now she's not hearing me, she's speaking, the Russian college. I have been visiting the Soviet countries. At that time, they are Soviet. And they have Soviet health centers. And in the Soviet health center, the general practitioner has disappeared. There are gynecologists, pediatricians, gynecologists, odontologists, physicians of work, many different physicians, not general practitioners. The general practitioners survived in the Soviet Union in the mountains where we were working. Why we worked the last 10 years of our life in the mountains? Because Mercedes and me, we like both become general practitioners properly, taking care of the whole population, taking care of the community problem, taking care of the school, taking care of everything, of teeth, of the fractures, of the pregnant, of the children. And the only way to do this in Spain now is going to very far away, isolate places. So you can read. I will send you, and you can distribute the paper, because my mother died in the year 2002. My mother was a very illustrated female for her age, and my mother read everything I wrote. And always, when finishing, oh, my son, it's incredible how wild you are. I cannot believe you are my son. But now nobody is reading all my papers, because Mercedes and me, we wrote a lot. So, nos hemos pasado 4 minutos. By the way, I had no payment for being here. No at all. And not because this meeting is longer. I do not try to make the meeting longer in order to be more paid. No, there is no money at all. Well,
we are a little bit out of time, but maybe we can continue.
No, I use the electronic mail more than WhatsApp. I prefer electronic mail. Yeah. So you have Twitter, and you can contact me, and you can discuss with me. I belong to many, but this is a concept. Who knows here the concept of invisible college? ¿Cómo se dice en inglés bien? Colegio invisible. Invisible college. Who knows? Muy bien, Bernardino. The old, yeah, Shema, oh, the old. Making sex is also the same, eh? The old is better than the young. Invisible college is a concept coming from UK, from the 17th century, before the official establishment of the of the scientific college. And the visible college are group of scientists who share knowledge before its publication. One question. We share knowledge before the publication, and we recognize people who think it's interesting joining us. Do you understand the two questions? And I belong to many invisible colleges all over the world. So when I locate some special doctor, I incorporate this to one of the invisible colleges. And this means 20 years of your life. I spent more than 10 years to be friendly with primary care, to establish contact with John Hopkins, and 20 years to have the recognition of many scientific people in the world. So when I invite you to join Invisible College, you decrease this time to 0. So you have 20 years of your life with recognition. Of course, it's not easy to be on this. I hope you. I have been here, I must say, because Chema called. I did not know that Raquel was here. I have been dishonest with Raquel. I never use PowerPoint, but because especially because the Saturno eating the song, I sent to her sister, and she prepared the PowerPoint, but only to your sister, not to you, to be sure that it's only her who see. Mercedes also had not seen it. So, Chema, this was to you. Muy bien.
We have a surprising present for you. Thank you for being here. No, it's your size. It's your size. But I just want to ask you a favor.
I hate trouble.
No, maybe it's a surprise.
I cannot wait. I make it silent.
We really know that you don't like the ties. You prefer the pajarita. Oh, well, you have another one of these, but just for you. We are going to ask you to take a picture all together with Juan in the front, okay? Sí, bueno. So come with us.
¿Qué dejamos? La pantalla. Esto lo tienes que a la tía. No, ya está. Hay que levantar esto. Sí.
¿Sabes cómo se quita?
Lo hace la chica, tiene.
Bueno, muy bien. ¿También para mí?
Claro, esto.
Bueno, tío, ¿qué he hecho yo para agradecer esto? Venga, dime que sí.